Understanding the Myth of HFpEF by Dr. Shantanu Sengupta. And the chairpersons for this session are chairperson was Dr. Sangram Brother from Gulbarga and Dr. Alok Rai from Raipur. Dr. Sangram Brother is Professor, Department of Medicine, MR Medical College, Gulbarga, Karnataka. Publications in various national and international journal. He is editor general, APKI Journal of Internal Medicine, Karnataka, and the area of interest in cardiodiaplogy. Dr. Alok Rai is past chairman, Chhattisgarh State API, he is scientific chair and executive member, CGCSI, member of various bodies, life member of various bodies, and has participated in various national and international conferences. Over to the chairperson to conduct the session.
Can I share my slide? You have to
Yeah.
Perfect.
So, yes, already Dr. Sengupta has been introduced. Over to you, sir.
Yeah, so I think continuing with the spectrum of diastology, I wanted to share the role of echo in understanding HFpEF, a very challenging situation. And so why do we need to understand more deep into HFpEF? Because it is a heterogeneous disorder. And interestingly, the one size defined by diastolic parameters doesn't fit all. An echo diagnosis of diastolic dysfunction and HFpEF, as Manish was telling, has been challenging, and a lot of things are now evolving over a period of time. And we desperately are in need of some good treatment for HFpEF. Causes of diastolic problem, HFpEF, are these: coronary artery disease, hypertension, diabetes, obesity, sleep apnea syndrome. And there are some unique structural, functional, and ultrastructural changes which are there in between HFpEF and HFrEF. As you can see, the volumes are more or less preserved in HFpEF. The wall thickness are higher, the mass can be higher in both. The remodeling of LV is mostly concentric in HFpEF as compared to HFrEF, which can be eccentric. The stroke wall, ejection fraction are more or less preserved, while in ultrastructural form, the myocyte diameter starts increasing. And there is an amount of fibrosis. If you do an CMR studies, fibrosis in myocardium can be interstitial or reactive, while in HFrEF can be a focal or replacement kind of fibrosis. Now, the concept of cardiac performance, we have been discussing that heart has a cardiac output stroke volume, which we can look by an invasive Swanson catheter. And we now have, it can be defined as a compression pump, looking at the LV cath and 2D echo to understand the dP by dt or ejection fraction. There is some concept of tissue pump where we look at the biomarkers, looking at the BNP levels and more cytokines. And we have seen about the strain analysis, which can be picked up by an echo looking at the muscular pump. And we do have an MRI-derived strain also. And the time course of HFpEF also evolves, starting precipitated by the comorbidities and risk factors. And there is a lot of interplay of multiple mechanisms which causes changes in the cardiovascular system, from remodeling to stiffness to autonomic changes to dysynchrony involvement of the RV side. And there is a component of low reserve where there is a change in the preload and afterload changes, which changes in the heart rate variability. And the patients can have clinical problems of reduced quality of life, effort intolerance, lung congestion, recurrent admissions because of comorbidity, and ultimately mortality. Now, HFpEF is an interesting thing, and it is mandatory to see that LV involvement may not be there always. So the myocardial involvement in HFpEF is a spectrum. So if you have a cardiac cause, isolated cardiac cause of HFpEF, as classically seen in infiltrative cardiomyopathy, but you can have an HFpEF kind of picture in primary renal failure, liver failure, or patients who are morbid obesity. So this can in turn involve the myocardium, which are causes extra cardiac causes of HFpEF, a classical phenotype which has been identified. So this is Sanjeev Shah's paper. He divided HFpEF into 3 phenogroups: phenotype 1, phenotype 2, phenotype 3. The phenotype 1 is a classical BNP deficiency syndrome where there is a lesser cardiac remodeling and the BNPs may be normal. The second phenotype, which we mostly commonly seen, is the obesity or a cardiometabolic phenotype, where there is an involvement of the myocardium characterized by impaired myocardial relaxation, they do have high prevalence of diabetes. And the third pheno group is mostly involving of the LV with RV dysfunction. The patients can have renal dysfunction. These patients have predominantly also are having atrial fibrillation. Now, why this is important? Because it has been seen that the prognosis of pheno group 3, that is the one with RV dysfunction and atrial fibrillation, is the worst and almost all three, and pheno to group 1 may have a better prognosis. Now, anti-proBNP, there are caveats. 30% of HFpEF patients may have it lower than anti-proBNP than normal. We do get false BNPs in patients with increasing age. It can be higher in women than men, and BNP may be higher in atrial fibrillation. False negatives, obesity decreases BNP levels. And so does a normal anti-proBNP during stable phase of decrease preclude HFpEF diagnosis? The answer is no. So remember, even if you are clinically suspecting HFpEF, if the BNP is normal, maybe you're dealing with the BNP deficiency HFpEF phenotype 1 in this group of patient. Now, this is the group where the patients, this is the mechanism they have shown. You have a genetic tendency, lack of wall stress can be seen in Africans, predisposes to hypertension, fluid retention, and high adiposity across the thoracic and chest wall, giving to a HFpEF kind of syndrome. The phenotype group 2, this is a classical cardiometabolic syndrome. In this, the global Launchpad strains worsens with increasing number of factors. There is a classical diastolic dysfunction, and the LV Launchpad strain and E prime velocity worsens with increasing waist-to-hip ratio. And this was presented in the Hypergen study. A good number of around 2,150 patients assessed. And the phenotype group 3, as I said, they are having a poorer prognosis, characterized with RV involvement, renal insufficiency, splanchnic congestion. AF can also be seen in sepsis and cachexia. They are mostly cachexia group of patients. Now, cardiac function parameters in HFpEF can be assessed by a lot of parameters: cardiac power output, cardiac index. But the most robust, which has been talked about in this meeting, has also been left LV global Launchpad strain, and there is more increment of identifying the LA strain in this group of patients. So HFpEF Launchpad strain is now defined as a marker of health of subendocardium. How good is your subendocardium? And as it goes towards positive, your subendocardium is not healthy. But if it is more than 19, you are having a healthy subendocardium. And this is the group of phenotyping of HFpEF. Again, from Partho's group, they said that if the LV ejection fraction is preserved, can also have HFpEF with reduced Launchpad strain, where the myocardium is involved more. But HFpEF can also have a preserved Launchpad strain, where the LV ejection fraction is maintained, global Launchpad strain is maintained, but still the patient has HFpEF, classically seen in primary left atrial cardiomyopathy, and can have isolated RV cardiomyopathy also. So this group has to be seen, that just labeling the patient as HFpEF with normal Launchpad strain is not sufficient. You have to look more. Yeah, we should start looking at the left atrial strain. So, abnormal LA mechanics, looking beyond LV. Lot of data. Manish told about this value of the LV reservoir strain. The cutoff, one of the studies say that anything more than 31.2 has a better prognosis when these patients are followed up over a period of time. LA mechanics in HFpEF should be identified. Now, this is a second phenotype classification which was given by Barry Burlaw. He's from Mayo Clinic, and it was an ancillary study of the RELAX trial. And he divided them into non-obese HFpEF versus an obese HFpEF. And as you can see, the non-obese HFpEF, the obese HFpEF have a higher edema. They have prior heart failure hospitalization. NYHA is more than the non-obese, but the left atrial enlargement is lesser. And as reported by Sanjeev Shah, also the anti-pro BNPs are lesser than the non-obese HFpEF. So there is a lot of interest in going into
Shantanu,
this
2 minutes
group.
left. Sorry.
Yeah, I'm almost done. So what is the treatment? Why this phenotype treatment is important? Because if you have lung congestion, you go for diuretics, caloric restriction. If there is hypertension, start with anti-hypertensive drug. But the most important thing is exercise training program is now getting identified in this group of patients. There is also interest of looking at the pulmonary vasodilators. But if you tell me, I was searching at the report, a lot of data has come up that exercise training does improve diastolic dysfunction in patients of heart failure patient. This is more data about 3-month exercise training, improving quality of life in this group of patients of HFpEF. So can diastolic dysfunction and HFpEF be prevented? The answer is yes. If you have a good caloric restriction along with a proper exercise, you can maybe not halt, maybe delay the progression of diastolic dysfunction and HFpEF. So thank you. This is the ultra macroscopic image of a fetal neural heart at 6 weeks. And as you can see, the diastolic function assessment, maybe if you can look at them, we can be able to have more information. Thank you so much.
Thank you.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.